Hello, everybody. Welcome back to Diversion Insights. My guest today is Meg Johnson Hall. Meg is a licensed nurse who has had a diverse career and has recently started a consulting company. Meg and I are both advisors for ProNexus Advisory, which is a group of independent consultants who really are top healthcare operations and clinical leaders. And with that combined group, they have such a breadth of experiences, and we could probably solve just about any problem you're experiencing. Welcome to Drug Diversion Insights, Meg.
Thank you so much. I'm very honored to be here and excited to have this conversation.
Me too, me too. Meg's work with controlled substances is something that she became involved in early on in her career, and she continues to this day, and that is what we're going to talk about. So take us, Meg, on a little bit of a journey of your career up to this point.
Great. I will. So yes, I have a bachelor's in nursing and started off my career. I joke that I had to do a 9-month period in med surg in order to be able to go into specialty. And so I did it was supposed to do a year, but I was done in 9 months because they needed additional psychiatric nurses at the organization I was working at in Wisconsin. And so started working with a unit that was both psychiatric and chemical dependency. And that had been my love I discovered in nursing school. So truly enjoyed working with the variety of psychiatric patients that we would get and all the different mental health disorders that they were struggling with, from depression to schizophrenia to chemical dependency to a whole variety. So I knew I kind of reached my area of passion that I really love to do. And then shortly, probably 2 years later, I moved out to Arizona and started working in psychiatry there, and absolutely loved that. I was working on a mood disorders unit to begin with, became the assistant nurse manager, and then became house charge and started doing psychiatric consults at the emergency department, doing assessments with the residents that were on call. And that was, again, just a phenomenal experience. Worked with both psychiatric patients and, again, chemical dependency patients. And then moved into a manager role. And the unit that I had was a 72-hour hold unit for a county. And again, truly enjoyed that work and working with the less privileged population and seeing some of the unique challenges they faced. During that position, one of the topics that came up that I got involved in was how do we manage when we discover either one of our staff are impaired on the job or we suspect that they've diverted medications, controlled substances from our inpatient unit. And so worked with some employee health colleagues and some other nursing leader colleagues and some clinician colleagues and kind of developed the new system for how we were going to manage if a employee was impaired. And I actually had 2 of my employees during my time there that actually went through that investigation process and then ended up in inpatient treatment. One had relapsed and one was a new diagnosis. Also worked with the state board while I was in Arizona and actually became a counselor for the state board group that they had to support nurses that were chemically dependent and were on some restrictions with their license. So I ran that group for about 3 years and learned so much, about how impactful this disease is and how it really works with nurses, and what drives them to actually, divert substances from their work or come into work impaired. It's just such a powerful disease. And then later on, I actually ran a adolescent unit, inpatient, outpatient, and residential for both chemical dependency. I was a program director for that. And then later on moved to Minnesota, started working for Mayo Clinic, and actually worked in their chemical dependency unit there for a while, and then went into other types of leadership. But maintained that passion, Later on, working in Arizona and Colorado, I continued to work on chemical dependency. My most recent project was working with a health system that had 12 different organizations in that health system. And they had done a really great job of developing a controlled substance management program for the hospitals in that system. But the ambulatory care and hospital-based outpatient areas were kind of disjointed. We had different processes with each of the different organizations. Some really didn't have much of anything for ambulatory care. So it embarked on about a year and a half long project with my pharmacy partner. And we created the organizational-wide controlled substance management program. And that was a challenge when you have 12 different organizations, all with their own processes, their own systems, how they work with pharmacy, what they have for storage, those kinds of things. It was a real challenge, but we were really super proud of the work that we created. We created new policies, new work standards, a resource web page, a monitoring system where we would do audits on an intermittent basis. And most of the ambulatory cares do not have Pyxis or any kind of system like that. And so, we really had to work with them individually to find out how to safely store those substances and also do a lot of education.
Wow, there was a lot in that introduction. It's like, should I be taking notes here just to ask some questions? All right, so let's go. First of all, it's great that you had a passion for the psychiatric space. That must be an extremely difficult and frustrating space. Um,
Yeah, I would say it's a
yeah,
little frustrating, but again, one has to, when you come from a medical background, you figure, okay, I can do this surgery, we can do this rehab, and then this person returns back to normal, and boom, we're done with them.
right,
That isn't the case in psychiatry. Most of the time, it's, there's short-term, depression or other kinds of things, PTSD, but there's other things that really need long-term care.
yeah.
It's more like managing some of your chronic cardiac positions or situations or chronic neurology diseases. They have to have that continued care. And that can be troublesome because you expect to cure them by the time they leave and you don't.
Mhm.
It's really helping them to manage the symptoms the best that they can and have the best quality of life.
Right. Well, and as long as you have people that aren't, mixing that with other substances that make the
Yeah.
disease state worse, or they're compliant with whatever medications are helping to control things. I mean, I think a lot of them, as you said, the underprivileged, or you might be
Mhm.
seeing homeless, or just people that
Mhm.
don't manage it well on their own.
True. And I think the newer thing that we've struggled with recently is the lack of access to care.
Hmm.
Whether that be an insurance issue or whether it just be a resource issue.
Right.
Many of the psychiatric visits and psychiatrist visits and um, are out anywhere from 1 to 3, 4 months.
Yeah.
So, you look at that and somebody's in a psychiatric crisis,
Yeah,
they
they can't
can't wait
wait.
3 months, and
Hmm.
even our inpatient care is now, 24 to 72 hours. It's really difficult to stabilize somebody in that short amount of time.
Yeah, absolutely. Okay, let's talk a little bit about your work in Arizona with the Board of Nursing and the counseling there. You said you gained a lot of insights on nurses in particular and how they get to that point and what they're thinking. Can you share a little bit about some of what you learned doing that?
Yeah, it was really powerful to run that group. I understood the disease and I understood the power of the disease, and that it drives you to do some things that you wouldn't do if you didn't have chemical dependency or addiction of some sort. But I really got to see almost the day-to-day struggles in and visualize that much clearer as I talked with these nurses on a regular basis and heard, oh, it was so difficult because I'm just starting back to work now and I have access to the Pyxis. And I'm supposed to get somebody to come with me when I get out a controlled substance out of the Pyxis, but many times there's nobody around. So do I let my patient just suffer for a little bit longer, or do I break my rules and just go ahead and get the control substance and give them the relief? So it gave me a lot of insight about how we need to better structure these experiences for these nurses when they return to work after going through treatment, and some of the day-to-day struggles that they really face, and the judgment that they face sometimes. It's very painful for them to have to admit, that they have this disease, and they have to rely on someone else to oversee them or sign off for them or those kinds of things. It's very much hard on their dignity. So I learned just a lot about that side of it, not so much the treatment side of it, but the human experience of going through this. And that when they get to this point, then it's just, what, it's better if I just go get high. And am I going to get that from the street, or am I going to get that from, my system? And so it's a coping mechanism as well as a disease. And we put them in situations that they have to cope with extra stress, from what they're already dealing with, family and finances and those things. So it was very,
Interesting.
very powerful.
Right. So I'm sure that shaped to some extent your work that you've done with people on a reentry program and what
Hmm.
those processes are. So what do you find? I mean, we want to keep their confidentiality, but
Right.
obviously if somebody needs to remove meds with them and oversee them, that
Yeah.
confidentiality is gone. I mean, everybody knows, what the deal is, right? Even if you don't say something.
Right.
So, what are your thoughts surrounding that? Well, first, I guess I should ask, are you a believer in reentry after treatment and recovery? And what are your thoughts on those parameters? And then, what do you think is a good way to do that reentry so that we preserve their dignity, but also make sure that
Mhm.
our patients are safe and we reduce liability for the institution as well?
Right. Yeah, I think, to me, it's a very, I've re-entered many people over the years, and I think it's a very individualized experience, as far as what we do and what is available within the organization. So some of the organizations that I've worked with, they've had much lower risk opportunities for people to re-enter back into work, whether it be case management or care coordination, or, working in maybe more of an ambulatory or urgent care environment, as that initial year of, okay, let's get you stable, let's make sure you're feeling comfortable being a nurse again, and then we can reintroduce some of those things. People that really love inpatient, kind of doing some of that case management or discharge planning kinds of work gives them an opportunity, or doing admissions. So there's always a creative way. I think one of the most important things is that their leader is very educated and understands the disease process, and understands both the advantages of this and the disadvantages. I think with the recruitment and retention challenges we have now, I don't know that we have much of a choice but to be open and receptive and creative in designing some sort of reentry program for individuals that have gone through this, provided the board allows that, the Board of Nursing. Um, but I think that's really, an important piece, and being a partner with a nurse on this, saying, what do you feel comfortable with? And we always had the nurse share with the other nurses that, I have some restrictions on my license right now, and so this is what I need, rather than us going and having a staff meeting and saying, okay, Susie's coming back to work, and by the way, she's an addict, and so you always have to sign for her. We can't do that, and that's not the right thing to do. So we say, how about if you just work on this wing or with this clinic, and then you tell the people, that you're just working with on that wing, that you need help and you need support when you sign out controlled substances.
Were most of them willing to do that? I mean, I'm sure it's probably kind of an awkward conversation for them. Um,
They really want to come back to work. Most of them, I won't say everyone, but most of them want to come back to work. And so
mhm.
having those really powerful, meaningful conversations before they come back to work about,
Mhm.
making sure they're ready, that they feel ready, and then developing a plan with them, not for them, on, this is kind of how we're going to look at, here's the choices, here's the options, how do you want to do this? And then letting them know, for confidentiality reasons, I can't share, that you have struggled with addiction, that you have to be the one to share that information. But I can help support you, I can help structure that. If you want me to be there when you talk with the staff, the couple staff that you want to work with, I can do that. So we're really offering whatever kind of support you can in that reentry program.
Mhm. Do you find that it's maybe another piece of the therapy slash healing recovery
Mhm.
process that they be able to express that this is what I need because right now I have restrictions? It's kind of saying that out loud is part of the recovery process.
I do think so. It's a difficult part. It's kind of like when they have to talk with their families and explain. The next step then is kind of talking with some of your coworkers and I even did role playing with them and rehearsing with them on how they were going to say that and what they choose to share because they don't have to share a lot. And some wanted to share more, and some said just nope. I just need them to know that I have a restriction on my license, a temporary restriction, and that these are the things I need help with. And so really kind of helping them customize it enough so that it meets the needs, so they do get the support they need, but yet it doesn't make them feel so vulnerable, and
Mhm.
almost violated. Um,
Right.
so yeah, but it is definitely a step in healing. I agree.
What have you found in general is the response of the peers that now know? Are they supportive? Are they judgy in general? I mean,
Yeah,
I know it varies, I'm sure,
yeah,
but
it
in
does.
general,
In general, I think most are quite supportive.
okay,
I've ran across a few that's like, oh no, that risks my license. I'm not having anything to do with it. Or they
sure.
become so controlling that the person
Uh-huh.
feels like they have somebody hovering 24/7 over them.
Mm,
But in general, I think if the leader is educated and understands and is supportive, generally most of the staff will also be supportive.
okay. And what do you find is a good length of time that somebody, I mean, obviously a lot of it is driven by the board and their
Hmm.
requirements or the treatment, the recovery monitoring system, and they have their rules, but do you have experience with people? I mean, okay, so you're doing this for 1 year, two
Hmm.
years, and then now 6 years down the road, I've heard of relapse then where you
Hmm.
think you might be in I mean, how do you, again, it varies, but at
Right, right.
what point do you think the facility can feel confident that, all right, been there, done that, we're good?
I think, and again, a lot of this is individualized, but,
Mhm.
I think if they've been able to go 1 to 2 years, again, depending on the stipulations from the board, and they've, typically the board also has them coming in for random drug tests. You as an employer can set that up as a part of your agreement as well to be able to do random drug testing. Um, I think you get to see how are they living the recovery, or as I call, are they living sober or are they living in recovery kind of thing. And
Yeah.
so are they really owning this and understanding this and really developing that trust with their peers. And
Mhm.
most of the time, I think that happens. But, again, part of the education with everyone is there is always a chance of relapse.
Mhm.
And we've all had employees that have relapsed. And so, again, the organization kind of developing and even letting that person know when you come back, okay, if you relapse, then, we're not able to take that risk anymore, or we're able to take it, depending on these circumstances. So,
Right.
yeah, there's always that level of anxiety and I don't want to say suspicion, but always a little questioning of, is this person after a year or whatever really ready to go solo?
Yeah.
I
Well, and
think
I think well, go ahead.
I think the other part of that is making sure that the organizations have good systems in monitoring controlled substances and doing the audits or running the reports, depending on what their system is, because then you will catch it. In addition to just being aware of the behaviors of how that person might look different. So, a big component in that is having the structure and having the education.
Yeah, and perfect actual lead into what I was going to say is that it wasn't too long ago that I spoke with somebody where the diversion monitoring person found out, well, there was a situation where there was some concern, and the mentor had actually started to notice a few things, but didn't
Mhm.
speak up and say anything. And then it wasn't until something else happened that they have a conversation and say, yeah, over the last month or so, I had noticed. It's like, well, my goodness, this is part of your responsibility. Why did you not say something? And so that comes back to that kind of educational piece, I guess, which
Right.
I don't know, maybe the mentor then is like, oh, I don't want to say anything. Maybe it's nothing, but maybe it is, you know, I mean, they have to feel
Right.
comfortable to say, I have noticed some changes.
Yeah, I think that's a really important point is which ties into culture, is creating that culture where people are comfortable saying, you know, I'm a little worried about this. I've seen this, this, and this, and I'm a little concerned. You know, what do we do next? Kind of thing.
Yeah,
Or, you know, talking to the leader runs some additional reports or does some other, you know, checking if it's paper system, you know, to
right,
really kind of see, okay, and just being aware.
right.
And then having that honest conversation with that individual saying, we're seeing these changes. You know,
Yeah.
can you share with us what's going on?
And that needs to be part of the whole reentry process. I mean,
Yes.
many facilities we learn as we go, right? We don't think of
Right.
something and then something happens and it's like, oh, we didn't know what to do there. So let's update our
Right.
processes because now we've learned from that. But that does need to be a piece of, you know, what do we do? Do we send
Mm-hmm.
them back to the monitoring program?
Mm-hmm.
Who's going to do the assessment, right? To
Mm-hmm.
see if there's something else going on. How do we handle that?
Yeah, and many times the boards will be very specific about what they do if someone relapses. And so sometimes as an organization, it's out of your hands, you know.
Sure. Yeah.
So it
But if we're
really,
not sure that they've
right,
relapsed, they're just
right.
like, you know, you're acting a little funny. Like, you know,
Yep.
what
And
is
I think
happening here?
that's an important part of building into your program, into your reentry program, is the ability to do random drug tests, so
Yeah.
that if you do say, I don't know, you know,
Mhm.
so and so's looking a little different, acting a
Yeah.
little different. There's been a couple questions, you know, let's just pull a
Do a
random.
test.
Yeah.
Yeah, sure. That could be the first level of, yeah, seeing what you see. Yeah,
Mm-hmm.
that's a good point. Okay, you mentioned you did some, I think the 12 system that you worked, the 12, that was ambulatory, correct?
Ambulatory and hospital-based outpatient.
And
Yep.
hospital. Okay. What do you see are differences in inpatient versus ambulatory or outpatient? Do you find that there are quite a few
Oh,
differences?
huge
Okay.
differences.
Yeah.
Um, you know, number one, there's not really, in many systems, there's not that commitment to have a really nice controlled substance program in ambulatory because the perception is they don't have controlled substances. Well,
Mm,
that's not true. You know,
right.
we had, I think, between 50 and 60 clinics that had controlled substances out of
Right.
112. So that's, you know, that's a significant amount. The other
Yeah.
piece that, you know, we've noticed is sometimes, you know, years ago, and you know those of us that have been in healthcare for a long time, years ago most of the nurse leaders that came into ambulatory had worked in inpatient, so they
Mm,
really had that full understanding of how tightly you needed to control substances and what you needed to do to manage it. Now we're seeing brand new nurses with maybe a year of ambulatory experience or maybe a little bit of home care or nursing home experience coming in and being leaders in ambulatory. They've never worked in a hospital system. They don't really fully understand, number one, what are controlled substances and what are the DEA requirements that we have to follow in order to do that. That's one of the big learnings we had, is that the majority of our nursing leaders did not understand what a clinician registrant was, didn't understand that you need to have a double lock, didn't understand that you need to do inventory, keeping the paperwork, you know, the invoices that come with the controlled substances. The
mhm,
other challenge in ambulatory, I mean, one, we're getting more and more procedures done. Um, we do have ambulatory surgery, and most of the time they have Pyxis. Not everyone does, but
mhm,
many times they do. Our endoscopy areas most of the time have Pyxis, but again, not always.
mhm,
And then a lot of our surgical areas in ambulatory that may do dermatological surgery, may do urological procedures, other things like that don't have Pyxis. And then a lot of other areas where they're, it's not as significant maybe of a controlled substance like testosterone, they don't have Pyxis at all. And many
Right.
times the areas that have Valium or Ativan, those, they don't have Pyxis either. So that creates a whole, there's not that tracking. There's not
Sure.
that record of, Meg signed in and took this, and we can see it in the Pyxis that she did, and we can run a report. There is no such thing. So you're reliant really on working with them to create a double lock system. And then again, we've had places with double lock systems that they throw the keys in an open drawer at night. And I know you've seen a lot of those same things. And so
Mhm.
it's really huge education from the top leadership on down, as far as what the fines are for this, what the
Mhm.
risks are for our staff, and what the risks are for patients. Um, and so it's really just kind of almost like an awareness across the country in
Sure.
ambulatory care that this is something you need to be compliant with and you need to be aware of and your staff need to be educated on.
Yeah. Well, I think a couple of things there. Do you think part of it might have to do with one, like you said, maybe not as many drugs,
Hmm.
but also there's no or very little pharmacy oversight because
Right.
they're not the registrant. So, you get a pharmacist in charge, and we are usually pretty, you do
Yep.
this, you do that, and we're watching. But when pharmacy isn't the registrant, they may have some oversight just to kind of, because it's part of the system, right? But it's not where the buck stops here. Um,
That's a really good point. We found that, some of our sites were getting it from our pharmacy, but our pharmacies have limits on how much they can support. I believe it's
mhm,
depends on the pharmacy, but 5%
yep.
approximately is what they can distribute out to ambulatory sites.
Mhm,
And so with us getting more and more controlled substance in ambulatory care, many of the sites, the pharmacy was no longer able to support them. So then
mhm,
they were going to outside vendors.
yeah.
And, the outside vendors don't have the same, well, the same system as far as transportation and verification and those kinds of things. So we were having some really interesting situations where controlled substances were just left on a dock sometimes,
Mhm,
with no signatures, no anything. So there's just a lot of education, especially like you said, if pharmacy is not involved in that.
right.
Um, to make sure that we are tracking that we're getting the chain of custody, and getting all of the information that we need to and the safeguards.
Right. Yeah. And so if they're not the registrant that is really in
Mhm.
charge, then as you said, it's getting probably the physician who is
Yep.
the registrant really engaged and understanding, as you said, what are the ramifications of having a
Being the
poor chain of
registrant.
custody. Yes.
Right.
And
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 there's
what
a
can,
lot of lack of knowledge there too. The
yes.
clinicians just get asked to, will you just sign off on this form and so we can order controlled substances? And they
Yes.
don't understand the responsibility that they have, when they
Yes.
do agree to be the clinician registrant.
Yes. And do you think there could be a bit of they don't understand just because they don't know what they don't know?
Mhm.
But do you think there might be a little bit of no one would want to do this if they knew? So let's not make a big deal about it
No.
from the institution's perspective. We just need a doctor to be the registrant.
I agree. I think there's definitely, number one, they're busy and that is not their focus, is,
Mhm.
how to manage controlled substances. And so they really don't take the time to research that, to learn. And then I think there's also that thing of, we just need them to do this. So let's not get into the weeds of the level of responsibility that this actually is and the risk
Right.
that they take on by being the registrant.
Right. Yeah.
Yeah.
Yeah. No, it's they just feel flattered we asked you,
Yeah.
but don't figure out what is involved. I think the other thing too is typically it's a much smaller group of people,
Hmm.
right? And so even in inpatient, you see that in a procedural area. They're
Hmm.
kind of that family. They're like, we got this.
Hmm.
Where we take care of our own. But I would think it's maybe even more in an outpatient
Hmm.
ambulatory surgery center type of a situation where we're family. We
Right.
don't have to have necessarily all of
Right.
those official procedures.
Right, because we trust each other. We're close.
Right.
Yeah, we work together
Yeah.
every day. Yeah, and
Right.
I think that's definitely a part. And we have non-clinical leaders that are clinic managers. They're business
Mhm.
leaders, And so
Sure.
there's not that knowledge again and understanding of that. And like I
Sure.
mentioned before, we have nursing leaders that have not worked inpatient and may not understand, even if they have, that this
Right.
transfers to ambulatory as well. And then we
Right.
have clinicians who aren't really taught or understand the responsibility too. So it's a little bit nerve-wracking, I think, to see some of the processes and just, again, the lack of understanding. It's no one's fault. It's
Yeah.
just that,
Yeah.
that knowledge isn't there.
Well, and on top of that, even in the inpatient side, many people don't
Mhm.
understand that diversion happens and
Right.
that a healthcare professional is just as susceptible to a substance use disorder as a non-healthcare professional. And
Yep.
so you've got that education piece on the inside, on the inpatient side, but then you translate that into ambulatory that doesn't have the pharmacy oversight to,
Right.
make you paranoid. And then a registrant that doesn't particularly understand all of that, and potentially no automated dispensing machines. And we're all a family and nothing has ever happened, right, to our knowledge.
In our
Um,
clinic, yeah. They might have
yes, in
happened
our
somewhere
clinic,
else, but it wouldn't happen
except
here.
not
Yeah.
us. Yeah. And so you put all of that together and you just do your thing until something happens and now you need to change how you've been doing things.
If you find out that something happens.
If you find, yeah, once it becomes clear that ooh, that's a problem, and then you become very reactive, right? But you
Right.
didn't
And
even realize.
having that investigation structure in there, who's on the investigation team? How does, that's one of the things we created was a worksheet for our leaders in our clinics, just because they were calling us all the time. And it was many times just that, Jane had given this dose of medication but hadn't made it back to finish documenting, or hadn't
Sure.
documented in the chart but documented in the control substance. And so, it's really helping them, guiding them through that first level of investigation of what has
Mhm.
gone in our clinic and where could be areas that I look to see if this truly is missing or not. And
Mhm.
then, if they find that, no, I can't solve this problem, then who do you outreach to and who helps you walk through that investigation?
Sure. Yeah, that makes sense. And then there's always the practice versus poor
Hmm.
practice versus diversion. How do we,
Right.
sort that out? Which sometimes it's not always clear.
Hmm.
Many times it's not always clear
Right.
exactly what's going on. Yeah. Can you share with us? You mentioned you had a couple of diversion situations while you were
Mhm.
in leadership. Can you share anything about either one of those cases?
Yeah, in one of the cases, we had two different ones. One of them, we discovered that some Ativan was missing um, when they did the count at the end of the shift. And so, we did our usual unit-based investigation to see if we could figure out, had somebody, forgotten to sign it out, or, cross-checking the charts versus the control substance record. And we found out there was not anyone that had done that. And so what we did was, we actually, then it was kind of having some conversations with the staff, and nobody could go home until we figured out this Ativan situation. And then going through and having conversations with people. The interesting thing was, we were partway through our conversations, and the unit clerk that we had, I went out to ask her to call somebody for me, and she was sound asleep on her phone, and it was ringing. I mean, sound asleep, passed out kind of on her phone. And her head was laying on the phone, and the phone was ringing, and she wasn't obviously answering it. And so
Ding, ding,
woke
ding,
her up.
ding.
Yeah, exactly. Woke her up and took her to the office to
You're
chat,
next.
and said, can you tell me what's going? Because sometimes there can be medical reasons for that,
Sure.
so you don't want to assume. So had some conversation with her, and um, through the conversation discovered she was having some real challenges in life, and said, well, based on what's going on, with you today in the unit, I need you. We need to walk over to employee health and have a drug test, and our policies and all that supported everything that we were doing. And so we did, and it came back with positive for drugs like Ativan. And so, then it was having the rest of the conversation. Another time, it was a nurse of
So
mine.
before
Oh,
you
go ahead.
tell about the other
Yeah,
time, so that was a unit clerk.
right,
So she did not have access to
right,
controlled substances, right?
right.
So somebody, was this not an automated
Yes.
dispensing machine? It was cabinets. Somebody, the keys were just out and she was able to get to it. Okay.
Yep,
Yeah.
exactly. And that was part of our investigation, was figuring out
Yep.
how did she get it. And so one dose she actually got because a nurse left it sitting in a little cup and asked her to watch it.
Oh, okay.
And when the nurse came back, she said, "Oh, I'm so sorry, it dropped on the floor, so I threw it away. I flushed it because I accidentally knocked it over working on this chart." And,
Yes.
we'd
Okay.
never had any suspicion. The
Sure.
other one, a nurse had actually left the cabinet unlocked for a couple of minutes while she went. It was a kind of a behavioral code situation, and she saw that opportunity to go in and help herself.
Okay. All right.
So yeah, you never know. You never know.
Yeah. Well, it's a good reminder. I mean,
It
those in
is.
the space know that it can be people that don't have access, quote unquote, and we need to be mindful of that, for sure.
Absolutely.
Okay. The
Absolutely.
second situation.
The second situation was an individual that was in recovery and was very honest and open about
Mm,
being in recovery,
mhm,
had not historically ever diverted from work,
mm,
was a nurse. And so that individual, this was an adolescent unit and we had an adult unit. They covered kind of both. And so we had a couple behavior codes where we had to actually give IM medications, Haldol and Ativan.
mhm,
And then what we discovered there was we had the multi-dose vial of Ativan, and that individual was very good and had actually been withdrawing. Anytime he had to go in, he would always offer to go in and prep the meds
mhm.
for the code.
Okay. All right.
And what he was doing was injecting sterile saline back into the Ativan
Mhm. Okay.
vial. And then he would use the other Ativan vial. We had two open, which is not our normal practice. He would use the other one for the patient and then
Oh.
continue. So it wouldn't be until we got to the next vial or somebody else would grab that vial that they would realize, wait, this didn't have any impact on the patient. Why not?
Mm.
And then he was filling syringes for himself.
Hmm. Interesting. Yeah. So it didn't point back to him, obviously, because anytime he
Right,
was involved, the meds seemed to work.
right.
Interesting. Okay. All
Yeah, that
right.
was one of the things I really learned was how creative, even for the
Oh,
drug
yes.
tests.
Mm-hmm.
We had individuals that would find a way to, have their child get a specimen for them, and then they would figure out a way to get that actually into the drug testing cup.
Mm-hmm.
So very creative in finding out ways. Again, that's the disease speaking, trying to help them maintain
Right.
their way of dealing with life.
Right. Right. Absolutely. Okay. If you could give people that don't really have a process, a good drug diversion program in place, a couple of pieces of advice, is there anything in particular that you would say is the most important thing or that they really should think about and
hmm
consider that they might not normally think about right away?
Yeah, I think the first thing is making sure that everyone is educated and that we kind of break through their denial that it can happen anywhere.
Hmm.
It
Hmm.
isn't just an inpatient or a pharmacy problem. This can happen anywhere. So I think doing the education with the staff of what to look for, how do we manage those controlled substances safely? How do you safeguard them? Everybody has a different system, but making sure those drugs are safeguarded from the time they arrive at your door until they go into, a patient's arm or into a patient's mouth. How do we
Hmm.
safeguard that? Um, and having, a really established process to do that, as well as a really fair, thorough investigation process. And then
Yes.
again, I can't say enough the education that's needed on what
Yeah.
those FDA guidelines are, what the DEA guidelines are, how do we make sure that we're in compliance, understanding the record keeping. So those kinds of things are just really critical.
Sure. Okay. Fantastic. All right. This is great. Thank you. It's a lot of great information. You've got a lot of experience in your background with this, and it was good to learn from you and hear what your experiences have been. Thank you.
Yeah, thank you for having me. Yeah, as you know, in nursing, it's just something we encounter on a regular basis. And like I
Hmm.
said, my background has been some inpatient, but the majority, the last 30 years, has been in leadership and in ambulatory care. And so
Hmm.
that's really kind of my area of expertise and in the area that I really focus on that needs, because again, we're adjusting as we get more and more procedures and more acuity in ambulatory care. We have to recognize that times are changing for us as well.
Yeah, absolutely. Okay, thank you. Thank you very much for your time, Meg. I've enjoyed the
Absolutely.
conversation.
Have a great day.
Thank you. You too.